Hello dear doctors, and welcome to today's video. This is slightly different, and I hope that this video is something that will be really beneficial for you, especially if you're struggling with how do we go about and solve MCQ questions. So in this video I'll be just going over one question from our question bank at CaptainMed.co. The link will be given down below if you would like to get the recalls and question banks yourself. And then I'll be going over the question, the stem, systematically going over all of the options, and basically giving you an idea of what your thinking process should be while you're trying to answer this question. So right now we have a 38-year-old male who presents with a right-sided flank pain radiating to the groin. He is nauseated but afebrile, and the CT-KUB shows a 5 mm stone in the distal ureter. His renal function is normal, but there's no sign of infection. So from these given options, which of the following is the most appropriate management? Is it A, immediate lithotripsy? Is it B, NSAIDs and expectant management? Is it C, IV fluid and morphine only? Is it D, emergency stenting? Or is it E, starting gentamicin? Pause the video now so that you can lock in your answer and comment it down below. Alright, no cheating. Alright, so the correct answer for this question is going to be option B. Alright, so why option B was right? Here's a short explanation on the website with the different differentials and why each other option was wrong, the high yield points, the clinical pearls, the references, the common traps, and memory hooks. Again, if you guys would like to have a look at these, we have these explanations for all of the MCQs. You guys can check out CaptainMed.co. So the patient had, let's say if he had an infection, or he had a stone that was bigger than 5 mm and it was stuck and not passing with conservative treatments or interventions, or there were complications such as obstruction, or there was uncontrolled symptoms, then we would be going for other interventions instead of going for option B. So now we move on to the first most important part, which is what is this question actually testing? So there are a few things that this question is actually testing. The first of them is going to be that does this kidney stone actually need an intervention? All right, and this is already established by the CT that was done to this patient. And there are a few factors that we'll always have to consider for kidney stones for all of the questions, and this is a systematic approach that you can use, which is the first one is going to be the size of the stone, then we have the location, and then we have if the patient has an infection, then renal function, then if there are symptom controls or no. All right, so in this case, if you extrapolate and we take this data, we find out that the stone was 5 mm. It was in the distal ureter, and the patient was afebrile. The patient had normal renal function, and especially this patient had no infection. All right, so for this demographic of patients presenting with these symptoms, we go for conservative treatment, keeping in mind the size, the location, if the patient is febrile or afebrile, if the function of the renal function is normal or not, or if the patient has infection or not. And this is the mental framework I would like for you to have, especially approaching renal stone questions. Now let us move on to the second part, which is breaking down the stem. All right, and in this we'll be discussing the symptoms that we had been given, which is flank pain radiating to the groin. Now I want you to take a minute and think, what type of pain is this? This type of pain is a classic ureteric
colic. Alright? Because as the stone moves through the ureter, the typical pain is going to be severe flank pain that can radiate towards the lower abdomen and the groin. Alright? And we can have nausea, then we could have vomiting, and these are some of the symptoms that accompany this ureteric colic. And the current Queensland clinical guidance describes renal colic similarly. And a useful clinical distinction for viewers that are viewing this patient is that
the renal colic patient is not going to be able to find a comfortable position. So in all of the positions, that patient is going to be very uncomfortable. Alright? And they often prefer to lie still because movement means they would have aggravation of that pain. Alright, so this is a very nice bedside pearl to have. Now moving on to our third point. Now this is a very important point. Alright, what is it? It's the stem having the size of the stone, 5 millimeters. Now the small ureteric stone has reasonable likelihood of spontaneous passage, and that is going to dictate our treatment option for this patient. Now the supplied question bank, it specifically uses less than 5 millimeters as a key size associated with spontaneous passage. So the person that has made the stem is deliberately choosing a stone size that supports conservative management. So you have to have a mental preparation that, okay, what is this examiner trying to actually test for me? Now along with this 5 millimeter stone, we also have that it's in the distal ureter. Alright, now the location matters too, because the stone has already traveled into the distal ureter, and it is closer to the bladder than a proximal stone. So we don't just read that it's a 5 millimeter stone, we also read that it's a 5 millimeter distal ureteric stone. Alright, now adding more to this is our next feature, which is the patient is afebrile. And this means that the patient doesn't have a fever, and this is one of the most important negative findings, because if one of the situations you absolutely do not want to miss is an infected, obstructed urinary system. Alright, and this can become a urological emergency, because first you have an infection, then you have an obstruction of that particular urinary system that has the infection. So Queensland guidance specifically flags renal ureteric colic with obstruction and infections for emergency management. Alright, and in this, if the patient has fever, pyorrhea with obstruction, it should raise concern for an infected, obstructed kidney. So we have a kidney involvement at this point as well. Another clue we have from this stem is that the patient has normal renal function. Right, and there's no evidence here that the stone is causing clinical significant renal deterioration, so we don't need an emergency management for this, or an intervention that's invasive. All right, now coming on to our answer. So why is option B the right answer? All right, now this option B is NSAID plus expectant management. All right, now there are really two parts to this answer. So the first part is going to be we are treating the pain. Now Queensland guidance lists NSAID for analgesia and ureteric tract calculi, and its clinical manual uses NSAID as early treatment for renal colic. So for an exam, if we have renal colic, we think NSAID. For first line, if there is no contraindication. Opioids can certainly be required if pain remains severe, but they don't usually replace the overall management strategy. Now the second part to this management plan is going to be that we give the stone time to pass. Alright, because the patient has a small stone, distal location, no infection, normal renal function, and no uncontrolled pain or symptoms. Alright, so there is therefore no indication in this stem for emergency decompression or immediate stone destruction. Hence we go for expectant management. Now using all of this information that we have spoken about right now, if you get a ureteric stone question, this is how I want you to approach it. Number one, size. How big is the stone? Because smaller stones are more likely to pass spontaneously. As stone size increases, spontaneous passage becomes less likely, and the chance of requiring urological intervention increases. Then we go to the location. Where is the stone? Is it proximal or is it distal? And this matters a lot. Next, we look at infection. Does this patient have an infection or not? Does the patient have fever, systemic illness, pyorrhea, UTI evidence, or sepsis? Number four, obviously we look for renal function. Is it threatened or is it normal? Because you have to look for AKI, significant obstruction, if the patient is anuria or oliguria, and sometimes the stem is going to give you a hint on this by giving you the milliliters of urine that the patient has passed. Then you have to look at if it was solitary kidney or either high-risk renal situation. Number five is, can you control these symptoms? Now, persistent severe pain or vomiting despite appropriate treatment can push management towards intervention or admission. And this one framework is going to give you a better approach to all of those renal colic questions or to ureteric stone questions, besides, other than just memorizing that 5 millimeter equals NSAIDs. Alright, this gives you a systematic approach instead. Now, if the question was slightly different, let's say, if the question was 5 millimeter stone that's in the distal ureteric, but the patient has fever of 39 degrees Celsius, the patient has rigors, the patient has hypertension. What do you do in this case? What treatment do you go for? Right now, this is an entirely different question. You should now especially worry about infected, obstructed urinary tract. The important concept is that in infected, obstructive urinary tract, we cannot give just antibiotics alone, alright? We cannot give antibiotics alone because they're not enough if an infected urinary system is obstructed. The obstruction may need an urgent decompression, such as ureteric stenting or nephrostomy, depending on the clinical situation and specialist management. And that is why option D is wrong here, but would become very right in a modified stem. So now we have established that option D would have been right in this situation, but not in our current stem. So now why isn't it option A? Now simply, it says that the treatment option is immediate lithotripsy. Well, immediate lithotripsy wouldn't be the best management because it's a method of treating stones, but this patient doesn't yet need immediate procedural treatment because the stone for this patient is small, as we know that it's less than 5 millimeter. It's less than 5 millimeter, and there are no complications given in the stem. The question bank specifically reserves intervention for stones that fail to pass or produce complications. So again, an intervention being capable of treating the disease doesn't itself mean that it's the best next step. And remember, for AMC, we need the best next step. Alright? Now moving on to why option C is not the correct answer for our current stem is that C states that we need to give IV fluid and morphine only. And this is a very good distractor because morphine can absolutely be used for severe renal colic pain, but now we come up with two problems for using morphine. Because the Q bank identifies NSAIDs as preferred analgesia in this scenario, and secondly, morphine only doesn't capture the key management decision because we are giving morphine just for the pain, but we don't have a plan for the treatment of the stone. Now, the expected management of a small, uncomplicated stone, the current Queensland guidance similarly places NSAIDs early in analgesic management with opioids available when there is severe pain. Why isn't it option D? Well, it's not option D because option D is emergency stenting, and we're not at the stage in this patient that we need a ureteric stent. Alright, now ureteric stents are usually there if there's obstruction plus infection. Alright, so if the patient had obstruction plus an infection, we would have gone for urinary stenting. Alright, and right now our patient is just afebrile plus no obstruction. Now, the urgency changes dramatically if the patient did have obstruction plus infection or sepsis, alright? And in the Queensland referral guidance, it specifically treats ureteric calculi with obstruction and infection as an emergency scenario. Now, moving on to why option E is not the right option, is that option E says we need to use gentamicin. And you'll be, that's the easiest option to rule out because there is no infection. Alright, the patient is afebrile and there's no signs of infection, so that's not a filler, it's basically giving you extra information. And it helps establish that this is an uncomplicated ureteric stent. It's an uncomplicated ureteric stone. And there are a few important clinical comparisons that you need to have that I would like for you to think of for these types of pain. Now, number one is going to be colicky flank pain, which is groin pain and restlessness. It's usually going to be ureteric stones. Then you have flank pain plus fever / urinary infections. This is most likely seen in pyelonephritis or infected obstruction. Alright, now if you have an older patient who has sudden abdominal plus back pain or back pain, sudden abdominal or back pain plus hypotension, it's usually going to be AAA, and this is the most important one that we need to test for before we rule out other pathologies. Now if there's flank pain plus hematuria, then stone is the most common differential diagnosis, but we have to also consider other urinary pathologies depending on the context. Now, the AAA point is particularly useful clinically because Queensland renal colic guidance specifically reminds clinicians to consider ruptured AAAs in appropriate patients who present with apparent renal colic, especially older patients. Before we end this video, I would like for you to always think about that. How could AMC change this same stem to have you thinking about the other options? One variation could be that they could have just, added an infection to this mix. Alright, and then we would have infected obstructed system, and in that situation we would need an urgent urological assessment, decompression or antimicrobial management. And at that point, conservative management wouldn't be enough. Now, another way could be increasing the size. Alright, instead of 5mm, what if they gave you a substantially larger ureteric stone that isn't passing? And then for spontaneous passage, that option would become unlikely. Alright, now we need to have a urological intervention for this patient. Now, another variation they could give you is renal impairment, so renal function is not normal. Alright, and in this situation, if the patient had stone plus rising creatinine or significant obstruction, and now this is not simply uncomplicated renal colic, I mean to escalate this situation. Again, coming to variation number 4, which is if the patient had persistent, uncontrolled pain. In this situation, the small stone is there, but the pain remains severe despite adequate analgesia. We don't just think that it's only 5mm, so we just send him home. Failure of conservative management changes this situation because this patient has uncontrolled pain. Now, the final pearl that I want you to take from this one video is this drug. Alright, tamsulosin. Now, this is a useful extra value point because most students often ask that whether every ureteric stone should receive an alpha blocker. Alright, do we give alpha blockers to all or not? Now, the current Queensland guidance or the current Queensland urology guidance says that an alpha blocker such as tamsulosin can be given as part of a medical management, but not the only medicine. Alright, however, there's an interesting nuance, especially for the Gold Coast Health Report. Alright, and this that an Australian multi-center trial found benefit particularly for large distal stones. So patients who had stones that ranged from 5 to 10 mm found to have benefit using tamsulosin, but the benefit was not there for patients that had stones under 5mm. So I would like to finish off this video by simply saying that just don't memorize that 5mm stones equals NSAIDs. Memorize this one framework that we used throughout this video, this golden framework. Alright, that 5mm stones does not always equal NSAIDs. That size, location, infection, renal function, and symptom control are the ones that determine the treatment that this patient receives, and this patient is uncomplicated, so we can give analgesia and allow the stone an opportunity to pass. So the final answer is going to be B, which is NSAIDs and expectant management. Now, coming back to our website, we see, again, correct answer B, NSAIDs and expectant management.
You can pause the video now and have a read through this if you like. And now let's look at the next question. I'm not going to give you the answer in this video. That will be another video itself. So we have a 65-year-old woman who presents with progressive fatigue and pallor. Blood test shows hemoglobin of 84, MCV of 70, ferritin of 8, and she denies having heavy periods. And she has no abdominal pain or weight loss. What is the most appropriate next investigation? So if you guys know this answer, just comment down below and we'll see if you're right or not. Thank you.